Welcome to Ballarat Health Services. I'm Kylie Holcomb from Health Information Services, and this is our presentation on nursing and clinical documentation. In Health Information Services, as you can see, we provide a number of services which are listed on this slide. Privacy, this is a very important issue to Ballarat Health Services. We're obliged under several legal acts to ensure the privacy of our patients and our staff. So we ask that you do protect patient privacy and that you only access information for valid work reasons and that you secure all information such as lists and notes. We ask that you don't remove any documentation, that you don't share your logons or passwords, that you don't access it for personal reasons, that no information is emailed externally, that you don't disclose any information other than that for its primary purpose, that you don't photograph documents or patients using your personal mobile, and that you don't post any information regarding patients or other staff on social media. We have a clinical documentation standard policy, and you can see the key points there. If you've worked in another site, you'd be used to this, but we ask that you be comprehensive, concise, accurate, relevant and objective with your notes, only to use common abbreviations and to use legible writing in blue or black ink. Each entry, as you know, must be dated, designated and signed, and if you make a retrospective note, label it as that and the time and point that the event occurred. We also ask that you put labels onto forms before you start writing. This is very important for patient identification. We did have an incident a few years ago where we had two patients with a similar name. One had a colonoscopy, one had cataract surgery. The labelling was done after the event and the labels got muddled up. So it took a lot of work to sort that out. In terms of our labelling, we ask that if no label's available, that you document the patient ID points onto the form, that you don't do any over-labelling if there's a wrong label on the form, that you cross it out and put a new label next to it if required, that you check you've got the correct patient before you add any notes to the existing forms and documents, that all pages of a multi-page form are labelled accurately, and that e-forms you have the correct patient episode before you start documenting. We'll cover a little bit about coding. So coding's translating medical statements to codes, and our coding throughput, as you can see, we average around 4,000 to 4,500 inpatients per month. It's a vital part of our funding at Ballarat Health Service, and the whole episode of care is reviewed, so all the notes that you write on are read by our coding team. When a patient's discharged or sent home, their record is sent back to Health Information Services where it's scanned. The coders get the scan notes, they read them, they assign a DRG, and all that data that the coders entered is then sent to Department of Human Services where our funding comes from. As you can see from this chart, the clinical documentation serves a purpose other than the concurrent patient care, and it's used across a variety of uses, particularly for clinical research and epidemiology figures. DRGs, you can read this from the slide here, what the background to these are. Diagnosis-related groups is the basis on which we are funded in the public sector. And then you have a term called WEIS, or weighted inlier equivalent separation. This is the dollar figure that we get at Ballarat Health Service for each WEIS, and every DRG has a WEIS value. DRGs have complexity splits, so the letters A, B, C, D, where they are used, indicate how complex a patient's episode may have been, and each one's funded differently with more funding to the more resource-intensive DRG. The splits work on comorbidities. So you can see in this example, we've got a low complexity F62B, heart failure and shock, and then the F62A, which is the more complex heart failure. And you can see reading those two scenarios what the difference is there. The coding rules, it's important to understand the coding rules and why we need things documented in a particular way. So coders cannot code from results and they can't code from a treatment. So you can see in this table here, a BSL of 1.4 and the administration of IV dextrose doesn't automatically mean a coder can code hypoglycemia. There are other examples there. In terms of the coding rules, to assign an additional diagnosis code, we need to see that a commencement, alteration or adjustment of treatment occurred, that a diagnostic procedure occurred, or there was an increase in clinical care. and this is what we rely on from the documentation. So to give you an example, we've got Mary who presented with a fractured NOF. It was repaired with an open reduction and internal fixation. We can see an MSU was obtained on day 4. It grew E. coli and the patient was started on antibiotics. What's missing from this scenario is the actual diagnosis of a UTI. Another example, Tom's admitted for an elective total knee replacement. He's got a history of hypertension. We can see his BP went up. He was reviewed by the medical team and increased captopril. The thing missing from here is linking the high blood pressure and the dosage change back to the hypertension. When you do something for a patient, we need you to document what that was due to. Other terminology you can use is secondary to, complicated by. The terms we can't use for coding are in the setting of or on a background of, as these aren't considered definitive linking terms. So if you can write that a BSL was 1.4 and a patient was administered IV dextrose due to hypoglycemia, that enables us to code it and capture it and ensure that we're funded for it. We run a CDI program, Clinical Documentation Improvement Program, here at Ballarat Health Services, and the objectives are as listed on this slide, which you can read in your own time. We employ 2 clinical documentation specialists. These both have a nursing background, and they work up on the wards reviewing notes concurrently while the patient's still admitting and asking staff to clarify information in the records. Feel free to approach Deb and Joe out on the wards if you have any questions about clinical documentation. Some nursing entry examples, and we understand that nursing staff aren't always able to diagnose, but they can document a finding such as potassium was 5.9 and that Dr. Smith was contacted, a phone order was given for Azonium due to hyperkalemia. So you can document the orders the doctor has given you and why that was done. You're able to document that a patient was commenced on Nilstat due to oral thrush, or that the wound care team was referred to due to a stage 3 pressure injury. In conclusion, if you can accurately document the true complexity of a patient's care, then the data derived from that episode will accurately reflect and inform our funding, our performance data, and all of our service planning. If you have any further questions about any of this information, you can speak to your nurse unit manager or contact Pauline, who's the manager of Health Information Service, or myself, Kylie, who's the coding auditor and CDI Program lead. And there are numbers for our unit as well. Thank you for your time, and we hope you enjoy your time here at Ballarat Health Services.